GYN-kreftkongressen ESMO i ferd med å avsluttes her i Barcelona. Vi oppsummerer de viktigste nyhetene fra denne kreftkonferansen med professor Mansoor Raza Mirza. Han professor på Rikshospitalet i København, og sammen med oss så skal han snakke om de viktigste nyhetene. ESMO is coming to an end. It was a very interesting conference here in Barcelona, but could you give us a highlight of the conference? Should we start with ovarian cancer?
Yeah, before starting, thank you very much. Before starting with ovarian cancer, I would just want to say that this conference idea started a few years ago, and it has developed to be a really major scientific event, not only in Europe, and now you can see internationally how many people are here from both sides of from Asia and from US. So this is one of the success story. We have quite a few young doctors who are networking. We have the senior doctors, and everybody's together. So I think this meeting has become is here to stay, and it's a great scientific success. If we take ovarian cancer, I think the major discussion we had was the hot topic, how to use PARP, and do we have are we going not to use PARP in platinum-sensitive relapse patients? And there was an amazing session where there was a great discussion which established very clearly that no, there is clearly a place for PARP inhibitors, and it has changed the landscape of our patients, given both in the maintenance setting, in the relapse setting, or in first line. And we can be very proud of our authorities, European Medicines Agency, that their pragmatic way of thinking, that they have kept all the labels untouched, and we can treat our patients with PARP inhibitors.
Was FDA has actually taken a few away?
Yes, and that's why the European Medicine Agency looked at it once again and had discussions. I was invited a part of that discussion, and we are very proud that the opinion of European Medicines Agency is, as we scientifically believe, is right, and they have not changed any label, and they're not going to change any label.
As you mentioned, there was a discussion about what's the best endpoint. Is it overall survival, or is it progression-free survival? The verdict, what is the verdict result?
So the verdict is, and that counts both for breast cancer and for ovarian cancer, you have now multiple lines of therapy. So if you're doing a trial in first line or at first relapse, after that patients will live longer and longer. You saw the results that patients are living for after progression on your experimental therapy for another 3 years or 4 years as median. And what does that mean? That means that you cannot control what is happening later. And there was a very nice paper now, almost 15 years ago, by Broglio in Journal of National Cancer Institute, and that showed that if you really want to show a difference in overall survival, if your treatment past progression is so long, you probably need 3, 4, 5, 6,000 patients in a trial, which cannot be done. And still you would not be able to control the treatment. And that means that the best endpoint, and that's why our guidelines and our consensus says the same, the best endpoint for ovarian cancer is progression-free survival. When it comes to the very late disease, so-called where platinum is not an option, where overall survival is short, typically in old days we call that platinum-resistant patients, there it is important that we look at overall survival with the patient-reported outcomes. But otherwise, progression-free survival is the endpoint. What you can do is you can find a middle ground. So the patients who have progressed on your experimental therapy, they get something else. And then they progress again. That we call PFS2. And that could be a surrogate for overall survival. So if that is also increase, then it tells us that there is a long-term benefit.
Yeah, and the PRIMA study, updated data from the PRIMA study, used actually that kind of endpoint. What would you say? Give us a few comments about the PRIMA study and the results there. It was a 4-year updated study.
Yes. So the PRIMA study, we're still waiting for events for overall survival. We in the statistical analysis plan, we need 60% events, and probably we will not be there until next year. So what we are looking at is the durable PFS. So what PRIMA study was doing is doing this exploratory analysis to see the patients who are responding, are they keep on responding? That's what you saw in this trial. So what we saw is these patients keep on responding for all 4 years, and that indirectly tells us the benefit of giving niraparib to these patients. So I think this is again a surrogate for overall survival, but it's very difficult when you have already given so many treatments. After that, you still have to wait for overall survival and what it can show, because this study is not powered completely for overall survival. So even when we have 60% events, we won't have, otherwise we should have had a multi-thousand patient study.
Also, the Paula study with olaparib presented new data. That was overall survival data, 5-year overall survival data. What were your reactions when you saw the data?
So both Solo 1, Paula, and Prima are positive trials, and the data that was shown by Isabelle Recocar on Paula 1 was very important, and by Kita LaRusso, it was very important because what you saw was that you have durable response, and you still keep the response both in the BRCA mute population and the efficacy, and in the BRCA wild type HR the positive disease. And that means that we see the same results as we saw PFS continuing until overall survival. So definitely a positive trial. Unfortunately, we still think that we should have had a third arm there, which was PARP alone. We don't have that. Now we are doing these trials. But the patients who need bevacizumab, we can add olaparib to that, and we now see long-term efficacy of that.
Should we move on to cervical cancers? There has also been interesting discussions about this disease. What's your comment on that?
So I think in cervical cancer, immune therapy has completely changed our way of treatment and the landscape. We saw in 2021 first phase 3 trial in the second-line metastatic disease with cemiplimab, the NGOT-CX9, and that showed clear overall survival benefit in a whole population, whatever disease type you take, against the single-agent chemotherapy, and became standard of care. Then same year at the ESMO Presidential, we saw the data of KEYNOTE-826, which again showed overall survival benefit of adding pembrolizumab to the triplet of carboplatin or cisplatin or carbo plus paclitaxel plus minus bevacizumab. So all this has completely changed the way we are treating our patients. What we have seen in the subgroup analysis, and which is very important, that patients who receive Bev when we are giving immune therapy has a better outcome. These are the hypothesis generating. So it's very interesting to see the results of the NGOT CX10 study, the BEAT CC trial, which will be probably available end of this year, where all patients receive bevacizumab. So I'm really looking forward to see the results of that. And then even more, bringing immune checkpoint inhibitors up front in chemoradiation, where we are adding plus minus immune therapy. These are the trials which will be show us probably we will move immune checkpoint inhibitors all in the first line.
So, lastly, Professor Mirza, endometrial cancer. You held also an interesting lecture about this type of cancer. What do you take with you back to the Rikshospitalet in Denmark concerning the discussions on endometrial cancer?
I think the most important message, which we have already put in our guidelines in Denmark, and I'm sure that that's the case in the rest of the Nordic countries as well, is that we must perform molecular classification up front for all our patients, because you saw that how we are going to, this is not one cancer, it's such a heterogeneous disease. There are different molecular targets, and these are druggable targets. So we can do the clinical trials and change the outcome of our patients. Again, immune therapy is going to change already now our standard of care in first line very soon. And then we will see other new trials resulting and changing our treatment. So I think endometrial cancer, we are privileged to see that how we have changed the way we treat these patients. As my colleague Ketel Russo said in the session, a few years ago, we could not have that session, right? And today, it's such a rich disease to look at the targeted therapy, what we are doing. And now we are already moving ahead. So if you bring immune therapy up front, what will happen next when they progress? So we are thinking to the next step.
So in your lecture, you use the term dinosaur studies compared to molecular profiling. So the point is, this is very clearly a disease that needs molecular profiling.
Absolutely, we should stop doing dinosaur trials in this disease, because this is such a heterogeneous disease. You have to find the right target and do the right therapy to these patients.
A great conference. Thank you for being with us, Professor.
Thank you very much. And two informations. First of all, do tune yourself to ESMO Virtual Plenary in March, 27th of March, where we will see the first-line data of NGOTIAN 6. Proudly, NSGO is global lead for that trial. Second, that the same conference is moving to summer from 24, and the next meeting will be on 20th and 21st of June next year in Florence. So mark that date as well. And having said that, everybody, please do remember that ESGO Congress is coming in end of September in Istanbul, and then moving to spring from 24, and on the 7th of March in Barcelona. Thank you very much.